Good evening. I'm psychiatrist Jay Fawver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 27th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call in the Fort Wayne area by dialing 969-2720, or if you're calling any place coast to coast, you may dial 866-969-2720. Now on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And I'll start tonight's program with an email I received this week. It reads, Dear Dr. Fawver, I'm 65 years old and I've had tinnitus since a young age. It means ringing in the ears. I've tried many supplements with no relief and was recently diagnosed with patulous eustachian tubes. That means they're kind of spread apart some. It's very difficult to concentrate on any other sounds to mask the tinnitus. Do you have any other ideas on how to concentrate on other sounds? Tinnitus used to be thought to be a mental health issue. Now it's not. So I want to stay in my lane, in my scope of treatment and scope of practice and what I do. It's an ear, nose, and throat issue where it's a physical disturbance on the inner ear, and that will cause a tinnitus. Sometimes there's disturbances in the brain itself, which is where the neurologist will take over. But as a psychiatrist, what I will hear about with tinnitus will sometimes the anxiety that's related to it. And I don't want to give any advice that would be ill-advised compared to what the ear, nose, and throat doctors would do. But basically what we will often do in psychiatry is give people medication that will decrease anxiety, but you got to get to the underlying problem. What will people do to help them with the outside noise? Sometimes they'll use extraneous kind of sounds. They'll use sound machines. They'll do various things to distract them. But I would certainly talk to your ear, nose, and throat doctor about ways of helping you be able to block out that outside ringing that you get with the tinnitus itself. Thanks for your email. Let's go to our next email. Our next email reads, Dear Dr. Fawver, my 16-year-old autistic grandson has an IQ of 156. He gets bored with homework but scores near perfectly on his tests. He is very direct in his opinions or comments, and his social skills are lacking. His autistic rating is level 1. How can I better relate or communicate with him? Well, the advantage of having autism is that they're going to see things from a different perspective compared to people without autism. And what I mean is there are some advantages from a cognitive standpoint of having autism. I say that because in the Israeli Defense Forces, the adolescents and young adults in Israel, they want to be part of the Israeli Defense Forces. But for years, if you had autism, you were excluded from being a part of the IDF. About 10 years ago, they started a specific team of intelligence agents within the IDF. And this team of intelligence agents had autism, and they have over 150, last I heard, of people with autism specifically on the intelligence teams because they can pick up signals and signs that a lot of people don't notice. So with autism, is it an abnormality? The biggest abnormality with autism will be that people have difficulty with socializing. And there's a reason behind that. If you have autism, this right front part of your brain, for instance, it lacks these particular neurons called mirror neurons. Mirror neurons are where you can actually mirror the behaviors and the mannerisms of other people. And whether we realize it or not, when we're talking with someone, we're often mirroring their mannerisms as a way of connecting. And with autism, you're having difficulty being able to pay attention to what other people are saying because you're kind of in your own world, and that's where people with autism will have pedantic speech. Pedantic speech means that they will often speak a little bit of a monotone, but they'll talk and talk and talk, and they'll often talk over another person because they will not have that social connectivity where they can maintain a conversation with somebody. So the best thing you can do with somebody with autism is try to help them with a autism specialists. Autism specialists for adults will help people with communication and can help you be able to communicate with your grandson. But keep in mind, he has some special skills. It's just that in our society, they might not be that apparent. And again, in Israel, they actually found ways to actually integrate them into a very highly specialized field in intelligence. I think we should be able to do the same thing in the United States, but that socialization aspect is often what they lack. And people with autism, as your grandson is saying, often have very, very high intelligence. We just have to figure out how to tap that intelligence and put them in the right spots. Thanks for your email. Let's go to the next caller. Hello, Gary. Welcome to Mayor's of Mind. Gary, you want to know what's the best book for a non-clinical person to read concerning mental health? The easy answer, Gary, is the Bible, the book of Ecclesiastes, a really marvelous book written by Solomon, pretty smart guy, concerning mental health. So I'm going to go with a secular book on mental health issues. I'd recommend Viktor Frankl's book called Man's Search for Meaning. Viktor Frankl was a psychiatrist before he went into the concentration camps during World War II. And a lot of people think he became a psychiatrist afterwards, but no, he wrote Man's Search for Meaning in 1946 after he got out of the concentration camps. But he had a very controversial theory concerning mental health, that being that most of mental health lies not in basic instincts, which was all the rage at the time. That was all the thinking with Sigmund Freud and Carl Jung. It's not based on instincts, but it's based on meaning. And Man's Search for Meaning is basically introducing the public to this particular therapy called logos therapy. Logos therapy basically is just saying that your whole well-being is based on having meaning, being able to cope with stresses as they emerge, and being able to enjoy life and be able to see things around you. We've seen that in the past 10 to 20 years in psychiatry. We've been paying attention to this symptom called anhedonia. Anhedonia means no fun. And when people are having no fun and they're not involved in pleasurable activities and they don't have meaning in life, they're more prone to getting more and more depressed. Now, it was thought in the concentration camps that people would become more animalistic as they lost more of their daily provisions for survival. They didn't. The people didn't become more animalistic in the concentration camps. The ones who lost meaning and lost hope were the ones who typically died. And Viktor Frankl noticed this while he was in the concentration camps, and it was kind of a way of using that environment as a lab for what he had theorized prior to going in the concentration camp. So that's why he wrote about it thereafter. Very, very fascinating book. I've read it a couple of times, but I was first introduced to it way back when I was in my 20s. So it's something that kind of reminds you that you've got to have some kind of meaning in day-to-day life. You have to enjoy and appreciate things around you. And when bad stuff does happen to you, because it will happen to you, you need to adapt, you need to be able to cope, and you need to be able to get through it. And that's the whole idea behind Man's Search for Meaning, because it reminds us that we have to have some kind of purpose for what we're doing every day, but also some kind of meaning behind it. Gary, thanks for your call. Let's go to our next caller. Hello, Darlene. Welcome to Mayor's of Mind. Darlene, you want to know about how does loss of vision affect mental health? It's a loss of sensory input, Darlene, that will affect people in different ways. If you're losing vision gradually, yeah, basically it can cause you to be more isolated, but you cope and you adapt to the loss of vision. If you're blinded abruptly, that can be a whole nother matter, but it's a matter of somebody's ability to cope with the sensory input they otherwise are experiencing and how well they're able to adapt. Often people who have a gradual loss of vision, they'll notice that their hearing is actually more clear. Stevie Wonder, the composer and singer, is a good example of that. He has exceptional hearing, and he can pick up on tones that people with vision will not be able to pick up upon, and we hear that a lot with people who have lost vision. So it's a matter of adaptation, but obviously if you lose your vision abruptly and you don't have time to cope with that loss of vision, that's more difficult. And it goes for a lot of different things. When we have an abrupt loss, for instance, if you have a family member who dies in an automobile accident suddenly one night and all of a sudden they're gone, versus another family member who has a gradual terminal illness where you've had 2 years to say goodbye to them, basically, it's a different type of impact on you. So an abrupt stress where you don't have the time to cope will often be much more detrimental for people. But the loss of vision, well, it all comes down to whether it's correctable, whether it's abrupt, whether it's gradual. They can all have an impact on a person's mental health. Let's go to our next caller. Hello, Saul. Welcome to Matters of the Mind. Saul, you're on a prescription by the name of Vraylar, cariprazine, and you're having terrible insomnia. You want to know about the question, should you ask for another prescription, or is there an over-the-counter medication that could help? Vraylar is a medication that at 1.5 and 3 milligrams can be very effective in helping with the mood and being added on to another antidepressant medication. But Vraylar has some side effects. Some people can have difficulty with restlessness, irritability. They can have pacing, we call it extrapyramidal symptoms. Akathisia is another word for it, but those kind of symptoms can be problematic for people, sometimes even at low doses. And I'd wonder, in your case, did you have the insomnia, the difficulty with sleeping, before you took the Vraylar, and it's just the Vraylar is not helping that much? Or did you take the Vraylar and all of a sudden you started to have difficulty with sleeping? If you took the Vraylar and it caused you to have difficulty sleeping, number one, we'll always consider decreasing the dosage or going off of it. But I'd want to know, is it helping you? If Vraylar is really helping your mood, we're going to work around it. So if Vraylar, let's say 1.5 milligrams, tiny dosage, is really helping your mood with the antidepressant, for instance, we might add something for sleep. And over-the-counter medications, a lot of those are merely antihistamines. I'm not a big fan of antihistamines for helping people sleeping because basically it's just blocking histamine, as the name implies, and histamine is what keeps us awake. The problem with antihistamines is it blocks histamine but keeps you asleep at night, but sometimes it'll carry over to the next day. Now there is a particular over-the-counter supplement that it's an antihistamine called doxylamine. It's the active ingredient, for instance, in Unisom. It's not too bad. It doesn't last as long as something like Benadryl might and diphenhydramine, some of the longer acting type of antihistamines. So doxylamine is a little bit more tolerable for a lot of people if they're going to take something to block histamine overnight, but we might consider prescribing some fairly inexpensive, non-addicting medications just to help you sleep better overnight if Vraylar is actually helping you. If it's not helping you so much and it's causing you difficulty with insomnia, that's a whole nother gamut. That's where we might have you go off the Vraylar and try something else. Thanks for your call. Let's go to our next caller. Hello, Winter. Welcome to Matters of the Mind. Winter, you had mentioned you don't typically get upset, and your husband says that is not normal. Is that something that needs to get checked out? Should I get mad at things more? That's a good question, Winter. I guess the question is, are you normally stoic? Are you having difficulty with emotional numbness? We call that alexithymia, where people don't feel happy, they don't feel sad, they just kind of feel blah. It wouldn't be normal if you're emotionally numb and you don't have a normal valence of emotions. So we should all have, based on the situation, happiness, sadness, anxiety, anger, apathy for that matter. Those are all normal emotions. But if you lack emotions, that could be a problem, especially if it's accompanied by something that I mentioned earlier called anhedonia, where you don't enjoy things. So lack of emotions, not enjoying things, that could be abnormal. Not getting upset with things, on the one hand, could mean that you have exceptional coping mechanisms, which is okay. Also, I'd want to know how you did with your growing up. Did your family members express their emotions? The issue would be, if you don't get angry overtly, is, are you getting angry internally, and are you holding in your emotions? That's not good for your physical health. So I think that could be your husband's concern. If your husband perceives that you're holding your anger in, sometimes that'll come across in various physical capacities, such as headache, skin conditions, bellyache, backache. When you hold your emotions in, it can be detrimental to you physically. And that's where it could be a concern if you're having any physical problems. But you could always talk things over with your primary care clinician and see if there's any concerns there. But especially if you're having physical problems, but yet you don't get angry about things that would normally be expected to cause a person to be angry, that's where you'd want to get checked out overall. Thanks for your call. Let's go to our next caller. Hello, June. Welcome to Matters of the Mind.
Yes, hi, Dr. Fawver. I just wanted to ask you, my mother is in the hospital right now, and we've been going through some issues of her seeing images as well as a projection of bright light over the top of her head, and seeing red dots on the wall, colors of green designs, but especially darkened images. They went through all kinds of blood work, no bacteria, nothing was found in the blood. First, we thought maybe she had a UTI. Urinalysis came back fine. I had taken her to the family doctor as well as the eye doctor, and the optic nerve and everything checked out fine.
Good.
So I'm just curious as to what you have to say regarding the images that will just not go away. She did have a mild stroke in the cerebellum, they said, but they thought that the symptoms that she was having had nothing to do with the stroke because it was just the images. Other than the dizziness, the off balance, she seems to be fine on balance, and no stroke symptoms as far as the face, the hands. She's very strong in the legs and the arms and so forth.
June, you gave an excellent history there depicting what your mother's endured. She had the stroke back here in the cerebellum, which can affect a balance. The vision area is right above it, and you're saying that part wasn't affected, correct?
Correct. Though the vision is fine as far as the eye doctor says. The optic nerve was checked. There was no problem whatsoever there. She has 20/20 vision. She had that little Doppler check with the little dots that come across, and she got that 100%. The pressure in both eyes was at 16. So when they tested her for the glaucoma.
That's really good. That's better than mine. With the images that she's seeing, is she bothered by them? Do they bother her?
Yes.
Do they annoy her?
Yes. Yes.
Okay. Is she confused in any way? Does she forget where she is? Does she forget about the people? Not at all confused, sharp as a tack with her concentration?
Yes.
Good. So that's
Sharp
where...
as a tack.
Yeah, so if she's sharp, that would kind of rule out the whole concept of delirium. They were pursuing that. Delirium is where you would be, it's kind of like an alarm system in your brain. If your brain is perceiving that you have a urinary tract infection, an infection of any type for that matter, or you have something that's not working so on the body, you'll have confusion, you'll have disorientation, you can have visual hallucinations with all that. So the good thing is it doesn't sound like that's the case. Here's what I'd speculate. Was it related to the stroke? Not directly. Was it a hemorrhagic stroke or was it a bleeding stroke or was it a blockage of a blood vessel? Did they tell you?
I think there was a little bleeding.
Little bleeding, that'd be a hemorrhagic stroke. So there's hemorrhagic strokes where there's bleeding out, and there's occlusive strokes where there's a blockage of the blood vessel. They work a little bit differently, but if it's a bleeding stroke, okay, what happens is, okay, it's in the cerebellum down here in the bottom part of the brain. What can happen is when you have a stroke, you have damage to the brain, which releases an excessive amount of this chemical by the name of glutamate. Glutamate is the excitatory chemical in the gray matter of the brain on the outside. If you have too much glutamate released, you can have things happen where the brain just gives you too much information, and it'll sometimes give you perceptual disturbances such as visual hallucinations or visual illusions. An illusion is where you kind of see something, but it's not really there. You see it out of the corner of your eye. She's having kind of distinct hallucinations. If they were not bothersome for her, I'd say, try to wait it out. But she might need something along the lines of something that's going to stabilize that chemical called glutamate. We'll use anti-seizure medications to do so. Based on her age, being an older adult, she might need something that's going to be a little bit more gentle and give her fewer side effects, and that could be a medication like Lamictal or lamotrigine. It stabilizes glutamate. We use it a lot for people who've had head injuries because we'll notice that when people have head injuries sometimes, June, they'll have the same experience. They'll kind of see the sparkling lights. They might actually emerge into experiencing migraine headaches, which will often be preceded by these visual disturbances like that, but it's all related to glutamate. So if you tone down glutamate, that can be helpful. It's tempting, and I know it's tempting for a lot of clinicians, to give her an antipsychotic medication. I don't think she needs that. I mean, for decades, we've always thought, oh, we give these people who are having perceptual disturbances, like those visual disturbances, as you've described, give them an antipsychotic. That might not be so helpful, and she'd probably even have more dizziness and lightheaded, so I wouldn't want to go that direction. I'd suggest number one, waiting it out as best she can, but she's bothered by it. So maybe something that could block glutamate transmission or at least stabilize it. And that's a medication, like lamotrigine or Lamictal. Depakote, or also known as valproate, does a really nice job doing that. It's kind of harsh. It makes you kind of sedated, but at tiny doses, sometimes that helps out not only with the visual hallucinations, but also with anxiety can be associated with that. Sometimes we'll use other medications like trileptal, also known as oxcarbazepine. Those kind of medications are basically stabilizing the excessive electrical activity that not uncommonly happens following a hemorrhagic stroke. So that's kind of what you've described, June.
Okay. Now, I want to tell you also, she had been sleep deprived for about a month. It seemed like she was not getting very good sleep also.
Wow.
And I think they put her on something called, I think it's Sequel or does that sound familiar? I might have pronounced it wrong.
Not ZQuil. That's
an
over-the-counter medication.
Not ZQuil. No, it starts with an S.
With an S?
Seroquel or
Seroquel. Seroquel would be quetiapine. Does that sound familiar?
I don't know about that.
Yeah, Seroquel at low doses helps with sleep, gives you a greater depth of sleep. At higher doses, it's antipsychotic medication. Higher doses of Seroquel can give you lightheadedness and some side effects of its own. So lower doses could be helpful. However, you'd mentioned she hadn't been sleeping. Was that prior to her stroke, June, or was that after her stroke?
Yes. No, it was prior. The month of December, she was having trouble.
Okay. Well, if she wasn't sleeping well, that can actually precipitate some neurological disturbances itself. Lack of sleep is a big stress for the brain and body. So lack of sleep could have maybe triggered some different things. And not that would have directly caused her to have a stroke, but it would have given her a greater likelihood because it's a stress on the brain. So is she still having difficulty sleeping? Now, she's had the hemorrhagic stroke. Is she still having difficulty sleeping?
Yes. Yes, she is. It's like the images will not go away.
Oh, my
and
goodness.
They keep her up.
Oh, poor thing. She might, at a low dosage, do well with a medication like Depakote or valproate. Again, you're getting double bang for your buck there. It's sedating, and she needs something that's going to be sedating, but it's also stabilizing or blocking glutamate in its excess. And there are options out there, and she can always talk to her neurologist about what kind of options that might be the case for seeing those kind of images, because the onset of the images were when she had the stroke, correct?
Correct.
I mean, that's something.
Correct. They think that stroke has happened within the last couple weeks, but the images, just started shortly after that. We've been dealing with it approximately 10 days now, so with the images.
Well, we're taught in our second year of medical school, June, to track back to when some kind of symptoms happen, and if they happen correlated with a medication change or some kind of medical change overall, it's probably related to that. So it might not be directly related to the cerebellar hemorrhagic stroke in that area, but it might have affected the other parts of the brain to cause her to have these visual disturbances. But it sounds like you've done the right things. You've checked her for glaucoma, you've checked the optic nerve, you looked at all the different factors that could be related to a visual disturbance, but I still think whether it's a head injury or any kind of traumatic experience for the brain, in her case, the hemorrhagic stroke, that probably is having something to do, and in her case, I think with a little bit higher glutamate transmission that could give her too much of an excitatory type of stimulation on the visual network, and that might be causing her to have some of those symptoms. So thinking more along the lines of at least the temporary use of an anti-seizure medication like Depakote, Lamictal. She needs her sleep. We might use something like gabapentin or Neurontin for her to get her to be able to calm down at night to be able to sleep, because sleep is healing for the brain, and she needs to be able to heal that brain over these next 6 months.
Okay. Thank you so much. I appreciate it.
My pleasure. June, pleasure talking to you. Take care.
Thank you.
Well, let's go to our next caller. Hello, Yolanda. Welcome to Matters of Mind. Yolanda, you want to know about REM sleep behavior disorder. Basically, it's where you're in dream sleep, and during dream sleep, you're supposed to be paralyzed, all right? So when you're in dream sleep, you're not supposed to be acting out your sleep. Because there's a chemical that's released while you're in dream sleep that just shuts everything down and you can't move. And that's why for some people, when they awaken during their dream while they're dreaming. I've had this happen myself. I imagine most people have. But you awaken and for a few seconds you can't move, and it's kind of scary, but then you can. But it's because that chemical's still floating around for a few seconds. So you're supposed to be paralyzed as you're dreaming. And REM sleep disorder is where you're not paralyzed and you're acting out, you're flailing, you're hitting your bed partner, all those types of things. So it's happening during dream sleep. Now, people often will confuse REM sleep behavior disorder with sleepwalking or night terrors, entirely different phenomenon. Sleepwalking and night terrors where you are screaming and you're very confused, that's happening in non-REM sleep or a very deep sleep. REM sleep behavior disorder, like the name implies, is happening just during REM sleep, just when you're dreaming, and it has to do typically with your body not being paralyzed during that time. And you want to know if you should see a doctor if neurological issues run in the family. Yeah, I mean, REM sleep disturbance can sometimes be a precursor to Parkinson's disease. It's not diagnostically related to Parkinson's disease, Yolanda, but if you have Parkinson's disease in your family, for instance, you might have a greater likelihood of having REM sleep disturbance because it has to do with the dopamine network in your brain itself. Yolanda, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions concerning mental health issues, you may write me via the internet at mattersofthemind@wfwa.org, and I'll see if I can get you a question on the air the next week. God willing and PBS willing, I'll be back again next week. I'm psychiatrist Jay Fawver, and you've been watching Matters of the Mind. God willing and PBS willing, I'll be back again. Take care. Good night.
Preceding program on PBS Fort Wayne was made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronMCH.com.